so that anyone who couldn't join this new time will still be able to appreciate all the sharing and discussion that we're going to hear today. All right. Well, we are so happy to welcome you to this webinar on provider behavior change resources. It's an initiative of the RMNCH working group and the SBC working group from CORE, because it's such an interesting topic that we can all continue to learn about and apply in our work. We have two fantastic experts who will share with you today. Christina Wakefield is a social and behavior change and health systems specialist, now a senior technical advisor with 20 years of experience leading global health initiatives. After spending the majority of her career with the Manoff Group, she recently began consulting and is currently supporting UNFPA on a really interesting adolescent health project in the Eastern Caribbean. And she's soon beginning work with the Healthy Brains Global Initiative to strengthen services for people living with severe mental illness and substance use disorders. Her expertise spans project leadership, strategy design, and applying behavioral science innovations to advance caregiving, RMNCH, nutrition, HIV prevention, with a strong focus on community facility linkages, primary healthcare, and sustainability. Christina is also the co-founder of the Anti-Collaborative, a Kenya-based NGO expanding access to home-based and self-care solutions in RMNCH. She has worked across Africa, Asia, Latin America, Caribbean, Europe, and US, and is an alumni of the Women Lift Health Leadership Program. Thank you so much for joining us today, Christina. Lynn Van Lith is our other expert, and she's now a senior technical advisor with the Johns Hopkins University Center for Communication Programs. Lynn previously was the technical director with Breakthrough Action and has a wealth of experience managing large programs and teams across 45 countries. Now, Lynn has graciously agreed to step in today because, unfortunately, the planned speaker, Kenyi, couldn't make it. He's in South Sudan, and there's so much happening there. For those of you who know Lynn, she gives all opportunities to colleagues and is a great mentor to all of us. Although she is deeply knowledgeable about the tools and concepts, she was really hoping Kenyi would be presenting this. So the fact that, Lynn, you agreed to do this is such a big favor for all of us, and we are so grateful. So without further ado, I would like to turn it over to Christina. And please feel free to put all comments, experiences, questions in the chat, because we'll have time at the end to get to that. Thank you.
Hi, good morning, everyone. So my name is Christina, and that intro was quite extensive, Lisa. Thank you so much. I'm really delighted to be here this morning, and just I think my task is to share a little bit about social behavior change writ large, and just set up the tools that Lynn will introduce. This is a topic that we have worked on, and I've worked on with Lynn. Actually, even a little bit over the years, and things have really evolved and moved quite rapidly for our field, I think, in the last 5 years. So thanks for being here. So for me, I always go back to sort of the very beginning of what is a behavior? What are we even talking about when we talk about social and behavior change? But what is really the outcome at the end of the day? And so it kind of really comes down to the way in which one, behaves, acts, or conducts oneself. But it's hard to sometimes figure that out. What do we really define as a behavior versus, especially in provider behavior change, the terms of reference of someone's job or the tasks that they go through, and what's the difference? And really thinking about it as answering this question of, in order for us to achieve our goals, in order for us to really make a change in the world that we're trying to change, who needs to do what? And that's really the behavioral question, right? The difference between that and sometimes what we as people that work in programming and public health think about is asking ourselves, what should we do? What should be done? What activity should we implement? What training do we need? What supply chain strengthening needs to happen? All of that is really important. But before we get there, the question that is really helpful to ask first is this behavioral question, because that is the ultimate the thing that will really drive impact is helping to change what someone does and sustain that. So this question of who needs to do what really comes first. And why is that so important? I just started sort of alluding to this, but really thinking about behavior first helps us really focus on what is that impact? What do we want to see happen as a result of our activities? So we might be able to help write a policy or pass a protocol, but it doesn't really change anything if it doesn't change someone's behavior. It also helps us define the problem and the challenges from the perspective of the person who we're asking to do something different. And then we can support that person to change rather than hoping change happens as a result of what we're doing. So social and behavior change is really the range of ways to actually prompt or facilitate that kind of change. This is a long definition, but in case we share the slides later, I kind of left this up. But it really aims to shift social norms and address all the factors that affect key behaviors. And that's really important concept because once we identify the behaviors we're trying to change, the way that we go about changing those behaviors or supporting changing those behaviors is to really figure out what would drive those things, right? Whether inhibit them or promote them, motivate people or constrain people one way or another. We have to figure out that pathway to change. SBC comes from lots of different disciplines, anthropology, economics, marketing, and sort of business. A lot of times, especially in the last decade, we've really focused on non-communication-based approaches or integrating communication with other kinds of activities and channels because can't just tell someone to do something. And that's really how communication often works, is prompting someone with information. And that's not always one of the factors or the most important factor. So really, I like this slide just because it kind of sums up the way that I think about this is that people are complicated, right? We all show up every day in our lives with lots of different things from our past, whether, where we live, who our family is, how we were raised, the color of our skin, our gender, our choices in terms of, marriage or not marriage, if we have kids, what stage of life we're in, if we've ever experienced illness, all the things, who our friends are, we show up with those things. And we can't expect people who we're working with in other places to not show up with those things, right? Just because they've been given a job to do. And so thinking about behavior change is really a way that puts all that complexity at the heart of what we're doing. And even in some ways honoring it, recognizing that that's what makes this world unique and important, and really dealing with that in our work. So provider behavior change is not just about that provider, because like I just said, providers, as we all know, are people, and they're showing up to their job as a human being first and a provider second, right? And so they are someone who exists and works within both a formal and informal set of systems that influences themselves as an individual, but also everyone around them. We're not talking necessarily when we talk about provider behavior change as things that they're doing in their life outside of their professional capacity, but we do have to recognize that they can't really separate, no one can separate themselves into full compartments. really, we're talking about specifically those behaviors that happen before, during, or after an interaction with a client in the facility. And there's lots of different things that fall into that. Um, and just like all behavior, what a provider does or does not do in the end is actually the outcome of a lot of different stuff, including things that are internal to them, like attitudes, values, beliefs, and skills, but also external, like their supervisor support, access to professional development, or a supportive workplace environment. So some behaviors that fall into kind of the provider behavior umbrella, you might have different actors, like the provider themselves, at different levels, which is also really important because someone providing community-based services might have a whole different system and set of issues that they're working within than a facility provider. Supervisors, government health system staff, potentially local leaders, and even the families and caregivers, just like providers influence family behavior, families can influence provider behaviors. And the kinds of actions that those different actors might be taking within this umbrella, and this is not exhaustive, might be assessing, classifying, diagnosing, testing, treating, counseling, referring, adhering. So these are some kind of the behavioral words that are helpful to kind of have in mind when we're really trying to isolate what is it that we're trying to ask people to do. So a really quick example, if we took sort of IMCI, one of the behaviors might be providers follow guidelines, but that's enormous, right? So breaking that down into smaller, very specific behaviors is often really helpful. So here we worked with groups of providers all over the world and really isolated out exactly what we're trying to do. And this is not revolutionary, right? This is very much based on the IMCI guidelines. It's just reframing it slightly from a behavioral perspective, right? It's just applying that lens. So instead of thinking about it from the program's perspective first, we're thinking about it from that user's perspective first. Once we get the behaviors, though, the biggest challenge is often, well, they're not doing those things. Those behaviors for IMCI are ones we've known forever, right? But providers aren't always following those things. So why? There's always, not always, but very often a gap between what providers know and what they're actually doing. For IMCI, for example, that is resulting in suboptimal quality of case management and persistent weakness in the assessment of the sick child and overprescription of antibiotics. We know if we dig in that training IMCI health workers is associated with better care. So that often results in this IMCI example in jumping to, we just need better training. We need different training. We need more training. And that's kind of where this space has focused for a number of years. But before we do that, it's really helpful to just stop for a second and say, okay, well, is that really what's going on? Is it that we need more training? Why is this adherence of providers to IMCI not sufficient, right? And this is where I think the rest of this webinar will come into play. There's a lot of tools and resources to help dig into this question of why, because sometimes it's hard to answer that. And we really have a lot of great resources that have been developed to help structure and break apart that question of why. But you'll see, and I think Lynn will probably talk about this, but there's just one piece of this that is about the provider's competency and their clinical skills, right? There's a whole huge other ecosystem that we really have to understand if we want to understand why. And I'll skip these slides. I can come back if we've got time, but just a little bit about how power dynamics sometimes influence that question of why also, which I really love. But once we have that question answered, why, then we build pathways to change that use that answer in order to craft the strategies. So instead of jumping straight to, we know that adherence is better when we have trained providers, so therefore we need more trained providers. If we need better trained providers, let's do training. We use the answers to the question of why to really figure out, well, actually, maybe what we really need to do is really build in this supervision piece. Maybe what we really need to do is create peer networks of providers so that they're able to share with each other, vent to each other, reference issues for each other. Or we really need to better tie, performance outcomes to performance reviews every year for providers so that there's an incentive for them to follow these protocols. Whatever those reasons are, that's really where the strategies then need to come in. This is kind of the output of the IMCI example. Part of what the issue was when we really dug into that was that the IMCI really is around integration, and a lot of the time health facility layout isn't conducive to that integration. There's lots of different pieces, and there's just not enough time or space or energy to really move people through those different pieces. And so there was an effort to really reorganize the physical flow of facilities in order to actually support IMCI. And in a number of places that really worked to make a difference in terms of provider adherence to those guidelines. So training and supervision was actually just one element of the solution and not really what was facilitating change. So just to summarize, the issues, you have to really start with where is this provider? And really think through all of the different things that impact behaviors, including other people in that system, not just the provider. And then for each factor that you've identified, determine the matching strategy, and then that's where we really build our programs. And that is SBC. So I feel like we'll probably do questions at the end. I will stop there, unless there's some, I don't know, Lisa, how you...
Oh yeah, if there's a burning question, please put it in the chat. Otherwise, we will certainly have plenty of time for a discussion. Thank you so much, Christina. And we're going to hand it over to Lynn now to get into these great resources.
Thanks, Lisa and Christina. Thank you so much. That was an amazing precursor. Really appreciate it. And to all of you, apologies again that Kenyi was not able to present today. I will do my best to try to fill in his shoes and see what we can do here. We're going to just start with a brief overview of the provider behavior ecosystem, which Christina just mentioned. I'll turn off my video so we can see everything here. And then I'll just provide 3 country examples from Johns Hopkins Center for Communication Programs that we have done in partnership with so many others. So let's go ahead and move to the next slide. Again, Christina did such a nice job of talking us through why provider behavior change. So I don't want to repeat that, but on the next slide, did want to just highlight and maybe elevate what Christina said, that providers are such critical actors in the health system, especially given their close and frequent interactions with clients, and that they're people too. And, we very much focus and appreciate that client-centered approaches, patient-centered approaches are absolutely central to providing quality health services. And we also need to remember to pay equal attention to healthcare providers. They're operating in incredibly complex systems, and we know that there is this bi-directional relationship between clients and providers that can make just a huge difference around quality services. So, centering providers as people and as human beings who have barriers and facilitators to their own behaviors. So on the next slide, and again, I'm going to go through these fairly quickly since Christina did such a great job, to really just, understand that if we are encouraging quality services, respectful care, effective communication, reducing bias and stigma, and building trust in services, that we really need to deeply understand how providers are interacting with clients, their own colleagues in any given health facility or in any community for community health workers, as well as the health system in which they operate. So on the next slide, we do provide this, I really spent a lot of time with many of the people on this webinar. So I really want to highlight that CCP helped facilitate a lot of this work, but we did it in partnership with so many people, both on this webinar and beyond, who operate day in and day out in health service delivery provision. So understanding again that providers are operating in these complex systems and that providers alone, don't often have the ability to make certain decisions because they are influenced by so many factors at multiple levels within the health system. So on to the next slide. As a result of this interest in developing a depth of understanding, we developed this thinking tool or facilitated the development of the provider behavior ecosystem. And it is a thinking tool to help all of us understand those wide-ranging factors that can shape and influence provider behaviors, observe some of the interactions and connections between these factors, and then really thoughtfully consider the different approaches, strategies, interventions that can be used to address the factors across that broad ecosystem. So let's move to the next slide. And thanks again to Christina for already sharing the provider behavior ecosystem map. This map is interactive and it visually represents this kind of vast ecosystem in which providers are operating. So there are many factors that appear, and at first blush, it can appear quite complex, but I want to help break it down a little bit here before we jump into the country examples. The nice thing about this example and the ecosystem map is that it's based on a huge amount of literature. There was a really extensive desk review done, and then we did a lot of interviews with people across many countries, and a variety of people were involved in developing this, as I already mentioned. So let's try to sort of unpack it a little bit. And again, I want to highlight that there are so many amazing service delivery tools already existing, and that this ecosystem map really complements those and can be used for quality improvement across the board. So on the next slide, it was, as I said, developed using a really rigorous co-design process, building on a literature review, and then ground truth with people in a variety of countries. And then we've held several expert consultations to co-design the ecosystem map. And I want to highlight here in the center of the map are the actors, the individuals, the groups, and entities that interact with providers across the system. So you'll notice on the right, we pull out some of the key actors and entities at the different levels where they operate. And the actors and entities are color-coded to align with the influence factors. So on the next slide, I want to also highlight the big buckets of influence factors. Those are on the innermost ring with multicolored blocks. So these influence factors are overarching groupings of elements that interact with one another, and you'll see the 7 listed here. In the interest of time, I'm not going to go into all of them, and instead go to the next slide. That highlights that if you go into the map and you click on any of the influence factor categories, you will see a description of the factor, how it affects providers. Here's just one example of the workplace environment and how the people, the culture, the governance influence how providers offer services. So I know this is sort of a quick rundown, but I wanted to, if we move to the next slide, and let me put in the chat for anyone who has trouble with the QR code, I'll also add a link to the website where you can pull out, let's see here, I hope that went through. That you can go on either through the QR code or through the link I just added in the chat. We also developed many, many materials. All are available in English and French. So there's the interactive website, several guides, briefs, as well as some of the examples that I'm going to dive into next. So let's move to the next slide. And again, apologies, Kenyi would have done a much better job than I will, since he is intimately involved in this work in South Sudan under the Wish 2 project. And so while CCP is leading the adaptation of empathways, we are very much working side by side with IPPF as the prime through this FCDO funded work. So on the next slide, maybe just to highlight as well that Wish2 is operating across 7 countries, including Burundi, Ethiopia, Madagascar, Somalia, South Sudan, Sudan, and Zambia. And I say Alfayo is on the line, so he can always chime in here if I'm missing anything. But Kenyi really wanted to provide an overview today of the work specifically in South Sudan, emphasizing some of the approaches that he and others have been applying there, including peer learning circles that include healthcare providers, and really trying to emphasize this respectful client-centered services, but with providers also being trained and centering the providers just as much. So on the next slide, I want to highlight empathways, and actually let me just put that in the chat as well. I'm sharing a link here to the Breakthrough Action website, but this work that I'm providing an overview on behalf of Kenyi is specific to South Sudan. And again, other Wish2 countries are applying empathways and adapting it. But empathways is a 3-round card deck designed to really spark important discussions and joint reflection between young people and family planning service providers. This first example is related to family planning and sexual reproductive health and rights. And the tool is focused on developing provider empathy for young clients and really encourage providers to pull from this empathy to deliver more youth-centered family planning and contraceptive services. So I think it's important to highlight here that the Wish2 project, in addition to focusing on youth, is also trying to engage other marginalized populations, including the disabled, and really try to understand the client perspective, make space for those clients who may have experienced trauma, not to mention the providers themselves who may also have experienced trauma in their own lives, given this country context. So you can see on the right here a screenshot of some of the posters, and it really, again, emphasizes the use of reflective exercises. If we move to the next slide, I know that Kenyi also wanted to highlight some of the additional approaches apart from the card decks, including coaching and mentorship, job aids, posters, and checklists that all kind of address some of these factors that are influencing providers in this context, to really try to reinforce respectful client-centered services, and also the feedback mechanisms. That client scenarios were developed to enable, really providing feedback to the providers to make sure that they have opportunities to continue to improve their services. And the final slide here related to South Sudan, thank you, Lisa, is additional provider behavior change strategies, integrating provider behavior change into trainings. And I love what Christina highlighted before, that trainings alone are almost always insufficient, that much, much more is needed to really emphasize and support provider behavior change within the system that goes beyond training, using data and feedback mechanism, recognizing and rewarding positive behaviors, and really continuing to link through broader health system improvements that do not focus solely on the providers themselves. So on the next country example, this is a maternal, newborn, and child health example, and I want to just give a shout out to Christina and Saman who are on the call. Christina, formerly from USAID, and Saman from AmeriCares, who was intimately involved in this work. So please add in both of you in the chat, or otherwise, other examples or things that you want to highlight that I may be missing. So on the next slide, this very much builds on the South Sudan example, and it kind of moves from empathy to compassion. Empathy, of course, stepping into other people's shoes, and compassion or compassionate care is really that empathy in action. We know that empathy and compassion are central improved client experience of care. And with this example, we wanted to build on the World Health Organization compassionate care rounds, as well as a wealth of data and evidence that shows the power of compassion and its ability to heal. And in this case, importantly, we highlighted client-focused interventions as well as provider-focused interventions. And for the purposes of this example, today I'm really going to focus solely on the provider-focused aspects of trying to really emphasize respectful care and providing support for providers. So on the next slide, very briefly to highlight the 7 intervention components that we developed jointly with the Ministry of Health in Tanzania in Mwanza district. We went through a human-centered design process to develop these intervention components. And you can see them on the screen here, ranging from compassionate leadership training, but not stopping there. We wanted to develop self-care practices for providers, as well as provider self-assessments, and then provide really intense mentorship and supervision for those providers, while at the same time ensuring that clients understood their rights. So you'll see there was a client charter that the Ministry of Health had developed long before we provided support in this intervention, but we developed posters, additional client feedback systems, and really try to incorporate that into the process so that providers were getting feedback in real time. So on the next slide, our research objective was to really determine if this multifaceted, compassion-focused intervention improved experience of care both for clients, but also if it led to positive outcomes for providers. So on the next slide, the outcomes of interest, I'm not going to go through them all here, but we really tried to take the provider ecosystem map and through the intervention, try to improve positive experience of care. And these are the outcomes that we measured through the study. We conducted a baseline survey, carried out the intervention for 6 months, and then conducted an end-line survey and had 3 intervention private sector faith-based health facilities and the 3 control sites. So quickly on to the findings. For providers, when looking at the effects, we assessed changes using a standardized globally tested index. And when examining provider perception of skills, 3 components improved significantly in the intervention facilities. And you'll see them listed here on the site, and you can see, or on the website, or sorry, on the slides, as well as the p-values associated. And when it came to provider burnout, 9 components improved significantly for providers in the intervention facilities. I won't go through them all again in the interest of time, and I imagine the core group will be providing these slides after the fact. But again, if there's anything that you'd like to talk about, any further depth, I'm happy to answer questions afterwards. But you'll see that across the board, providers really felt more provided or more supported through their health facilities, and really, found more resilience in their work. And on the next slide, I just want to highlight that organizational support from their health facilities, from their supervisors, from the health system, even from the district increased. So intervention facilities reported a significant increase in their perception and support of the health facility across 6 components that you see here on the slide, and 100% of the providers believed that the intervention was culturally acceptable and appropriate, and 92% of the providers would like to continue implementing the intervention. Now, if we move to the next and final slide around clients, importantly, the intervention also had positive outcomes for clients. 360 clients were interviewed at baseline and half at endline. And again, across those 6 facilities, and all of them showed significant improvements, and the results were highly statistically significant across every one of the components of the scale you see on the slide. And let me just add a little bit more. If anyone is interested in reviewing more around this study or wants to download the intervention components, they're all there listed in the chat, so please feel free. And then I want to move to the final country example quickly, focused on malaria from the DRC. So here, again, we worked very, very closely hand in hand with the district health management teams to really unpack, again, applying that provider behavior ecosystem, which of the factors were most pressing and which really required further investigation to understand the causes of suboptimal malaria service provision. So we developed a tool on the next slide, and I'll share a link on this one too, that really provided a structured, flexible process to understand from providers themselves. It was not a checklist of sort of yes, no, but it was much more qualitative in nature to gather not only the perspectives from healthcare workers, but really ask them, what do you see as the challenges? So it was part of the inquiry process and then the solution development process that they were central to both of those. So we applied on the next slide some core principles that we wanted to complement existing data sources, really deploy that systems lens. And rather than applying sort of a what's wrong, what's not working here, we wanted to use a strengths-based lens, a supportive outlook to ask providers themselves, like, hey, we understand you're operating in some difficult circumstances. Sometimes you have stockouts. There are lots of challenges that they are facing on a daily basis. But, asking them, what do you think you could identify as opportunities for improvements? So on the next slide, and I'll just go through these very quickly, we applied this 4-step process with them, identifying facilities for further inquiry. Secondly, doing a phone call to confirm if a need for a visit was there. And then we did do site visits at several facilities, at 6 facilities, to identify what are the influencing factors. And then the 4th step was really synthesizing the findings with the stakeholders. And by stakeholders here, we're talking about the district health management teams, the provincial focal points for malaria, as well as the in-charges and the providers in each of those facilities. So on the next slide, as I mentioned, we visited 6 health facilities, a mix of public and private sector sites, urban and rural, and worked very closely with the National Malaria Control Program to apply this tool. So on the next slide, some key insights, and I apologize, I know I'm going fairly quickly through these, but there's far more information on the website if you want to dive into any of them. But I just wanted to highlight some of the learning here that, regardless of the size, location, number of staff in these facilities, there were some similar factors shaping provider behaviors. And so you can see them listed here on the slide. And even though the facilities were quite different, we found that providers were coming up with a lot of the same challenges. And sometimes there is ambiguity in staff roles, or there was poor data recording across the board. But again and again, health providers displayed incredible resourcefulness in figuring out workarounds for some of the challenges that they faced. And even in spite of these challenges, showed incredible compassion for their patients and really were doing the best they possibly could given the circumstances. So on the next slide, this is more just sort of reflections on the tool itself, but we found that open-ended qualitative nature of the tool was really helpful because it's not enough to identify that there were challenges. One has to really dig deeper and figure out why were some of these bottlenecks there? Why were some of these inefficiencies present? And then work together with providers to help explain what actions could be taken to address these behavioral drivers and these social drivers, including team culture and some of the norms in the health facilities that were underpinning some of the challenges faced. So let me also just quickly add here the link to that tool in case you want to provide or look into that a little bit more. And the last slide here, thank you, Lisa. Or if we go one more, is just some of the lessons learned. And I think this again amplifies much of what Christina had already shared, that provider behavior is shaped, sure, by individual factors, but so many systemic factors really do shape what providers are able to do and not do. We also want to, emphasize again this idea that empathy, communication, and compassion are absolutely essential. Clinical skills, of course, are important, but these quote unquote soft skills, which I don't even like that term, are equally important as the clinical skills. If providers are not able to connect with their clients as human beings, if they're not able to show empathy and compassion within their health facilities, even with one another, it's very difficult to provide quality health services, regardless of the health area that we're talking about. And again, to amplify what Christina already mentioned, training is not enough. There is so much value in continuous learning, coaching, and that ongoing supportive supervision that we really need to continue to support. And really that empowering providers improves both client experience and health outcomes, which is fairly obvious, but maybe worth restating. So with that, thank you very much. I will pass the baton back to Lisa. And I see it again, so many colleagues. Grace Maheso is on here. She could write a book on this topic, as could so many others that I see on the call. So thank you again.
Wow, just incredible richness. Thank you so much, Lynn. I will have to go through all these resources myself too and remind just amazing work. I'd love to welcome any questions. If you have questions, please type in the chat for Christina or Lynn, or share your experiences working on these tools or others. Yes, Sarah?
Hi, thank you. So
Hi.
I used to work for CARE, and we had a project where we also saw similar thing. It was a project to delay first birth among married girl, very young adolescent girl in Niger. And what we realized is among the whole package of SBC intervention we made, the most impactful one that showed most result was the healthcare provider transformation. Basically, we went from healthcare providers, especially head nurse, who were very resistant to advising a newly Paris girl, the one that never had given birth before, to take family planning method of fear of misconception about, fertility and the fact that the girl may become more promiscuous with other men instead of their husband. There was a whole area of reason. And we saw that actually that was the most impactful intervention from the girls themselves, the adolescents who say they felt more comfortable going to a healthcare provider to ask questions when before it was just informative, to actually the parents, the environment for the girl, as well as the husband, that say that they saw a big difference, and also the healthcare provider themselves who say that they felt that they were able to basically become advocate for the girls when before they merely saw the responsibility to basically help deliver babies, pretty much after the girls. So I just want to say it was, and the tool that was used was CARE signature social action and analysis. So same thing, a lot of like reflective exercise about how to improve, the perception that the healthcare provider had of newly Paris girl, of family planning, of their role, etc. So I just want to echo the same thing. It's very interesting. I'm looking forward to be able to look at the tools, to be able to see what we can do in other area, and with other like groups that tends to, I would say, be more heavily influenced by healthcare provider. I see adolescent girl are the group that can be most influenced and that could benefit the most from the fact that they do their job, with compassion and care. Thank you.
Thank you. Rondi, please come off mute. Yeah, thanks.
Thank you. I unfortunately didn't hear it all because I had a conflict for some of it. So I will listen to the recording, and I'm very interested. But one of the things from what I saw that made me think about is that I have in the past worked with respectful maternity care, and I found both for myself, but also watching other people do interventions, that telling people to be respectful often sort of fell on deaf ears. Like, people don't realize that what they're doing, it's so ingrained in their habitual ways of interacting that they don't know that they aren't, or that they think that they're that they have to do it that way. It's how they do their work, kind of thing. And I've seen awful examples in delivery rooms,
Mhm.
striking, where people were good people, bright, and doing horrible, harmful things with being oblivious to it. So one of the ways that I've responded to it is by having like WHO has pretty clear guidelines. Do this, this is what's quality routine care, this is harmful behaviors, but delineating those kinds of things. I mean, it can be as simple as she should have a companion with her, or that kind of thing. And I have found that easier to get people to make changes, and also for supportive supervision for those that are supervising to be able to monitor it. And I guess I just threw it out there to see if other people have similar kinds of experiences. Over.
Great, thanks. I'm sure both speakers could talk about how to support those behaviors, but I see Christina Granger, you've raised your hand, and I think you would also have wonderful insights on this. So
Yeah,
please.
thanks.
Yeah,
Thanks, everyone. Sorry, we have flu going around my house. I guess I'm getting it. But thanks, Lynn, for presenting our awesome experience in Tanzania. It's so nice to kind of be back in the mix and feel like excited about that work again. But just to respond to Rondi, I totally agree with what you're saying. And I think part of the reason why in that work in Tanzania, we decided to focus on this aspect of compassion was because we were seeing a lot of the evidence coming out of actually the high income countries on compassion, compassionate care, reducing burnout. And a lot of that was because there was research that showed that kind of this idea that compassion begets compassion. So the idea that if from the higher up, starting from the top, if health workers themselves are treated with respect and compassion, then that influences how they treat their clients. And so it's kind of this from top to bottom and bottom to top aspect, that also the same, that if clients are respecting the healthcare workers, then they will get respect back. So it's this whole kind of symbiotic relationship of kind of compassion and respect. And Tanzania was unique because they had a respectful care training already, respectful maternity care especially. They had, as Lynn said, they had like a doctrine in all of the hospitals and the like, but it still wasn't exactly translating to respectful actions. And so that was why in that project, we really focused on this idea and this concept of compassion. And that was something that really resonated when we did the co-design workshop. It really resonated with so many folks. I think maybe it was kind of more tangible than this idea of respectful care, which is this like really big thing. So yeah, I totally agree with you. And I think a lot of that was because it has to come all the way from the top, and it has to go both directions. Otherwise, you'll keep having the same issues over and over of this disrespect and abuse. Over. Thanks.
Thank you.
Fantastic discussion. Thank you. Does anyone else have a question? Or I have a couple for Lynn that came to mind. Okay, well, I'll go ahead. Lynn, what you said about the traumatized providers in South Sudan really stuck. And I was wondering if you're tracking or exploring how this work around empathy and compassion are helping the providers as well.
Thanks for the question, Lisa. And Alfayo, I don't know if I can put you on the spot to see if you want to share some of your experience in Somalia as well. And I know you've been working really closely with Kenyi in South Sudan. Do you want to take this one?
Yes, thank you very much, Lynn Van. And I agree with the discussion that the provider behavior, especially the empathy ways, not only support the healthcare workers to provide empathetic services to the clients, but themselves also have reported that the interventions have helped them themselves. I have been involved in rolling out the provider behavior change through using empathy ways right from the Breakthrough Action Kenya, where I worked with Dr. Gretz and another team of people who are also in this meeting. And when we did the analysis, where we used to have the routine engagement with the healthcare workers just to have reflection and review. And a number of them were able to report that even themselves, they were able to improve their relationship skills with their own children, with their own families, which have reduced the level of distress among themselves. Same applies to Somalia, where the country is fragile and has gone through a long period of turmoil based on the war and conflict. There are healthcare workers who are also reporting that they are using the same skill set they got from the training in their own household level. One of them reported that even his discussion with his wife has improved, and now he no longer dictates to the wife, but he was able to apply the skill set and encouraging the wife to speak up so that they were able to have dialogue, and the tension in their household was able to go down. So I just want to confirm that the empathways, which is healthcare provider behavior change interventions, is not only supporting the quality of care to the client, but also addressing individual trauma at the healthcare provider level. Thank you, and over to you, Lynn.
I have nothing to add. Thank you so much, Afaya.
That is amazing to hear. Thank you for sharing that. We can see all the ripple effects of this wonderful work. A question for Christina. I appreciated how you had the question like, wait, but why? And wondered if you could recall any surprising factors in your work that influenced provider behaviors.
Gosh, that's such a good question. One of the most interesting things that I have done with this was we worked a few years ago with the Midwifery Association in Ghana. And initially, the plan was to help strengthen the continuing professional education program, which in Ghana is actually quite amazing. It's really robust. They have everything on a really, really well-developed online platform. And I think the number of trainings accessed from that platform, it's definitely the highest on the continent, but it's also, the number is something incredible, like 500,000. I can't remember it right now, but it's really, really, really amazing. But for some reason, that wasn't really translating into actual improved services, or even the feeling that clients or that providers self-reported feeling of competence to handle certain kinds of tasks. And so when we really explored what was going on and where the pathway to change was breaking down, we learned a couple of things that one, that people were being given certain trainings almost as kind of rewards or favors, and not necessarily being matched with trainings that they needed that were really focused on filling skills, right? It was a requirement that there was a certain number of trainings completed to maintain certification, but it wasn't really based on need or what really was going on in that particular part of the country. So I don't know that this is necessarily like a huge surprise, but it really felt, I think, surprising to the Midwifery Association as well as other members in the Ghanaian government, because I think they were looking at the output of this training system and thinking, we're doing an amazing job. And they really were, because that was a huge feat. But then just getting it over kind of the last mile was really making sure that that system was really well connected and really well integrated within the performance, sort of the annual review process, and even provider promotion and a career path. And so supervisors, what is part of the annual review identify recommended trainings or recommended continuing professional education opportunities that were specific to where the provider was interested in growing, and also those skills could be used and applied at the clinic immediately following. So it was a really big shift in the way that things worked. And of course, it's easy to talk about it, and it's harder that system is large and slow moving. But there was really some change made in the way that the certification was granted. So it was really cool. And I think that's where you wouldn't go into that expecting behavior change to be something that's central to the way that program worked. But it was really helpful to everyone involved to try to really understand kind of where the breakdown was happening between all of this training output and then the fact that the services weren't really changing.
Nice. Christina, Meredith put a really good question in the chat. Meredith, if you want to say it, feel free. Otherwise, I'll read it.
Okay, sure. Can you hear me?
Yes.
Okay, great. Yeah, so my question was more about the planning and budgeting for these types of projects where, it's wonderful if you can identify those barriers and what you're going to work on before you design the project. But usually, in my experience, you kind of need the funding to kickstart those conversations. And I feel like one of the barriers we so often face, and one of the reasons we often find ourselves falling back into training, right, is because it's really hard to sell to a donor a project where you don't know what the activities are going to be. And like, maybe it's going to be training, or maybe we're redesigning health facilities. So just wondering if you have any tips on how to kind of do a detailed implementation plan or a budget for this kind of project where you might not be getting that information from the providers on how to solve their behavior change challenges until the project is already going.
Yeah, that's a huge question. And I agree. We, for a long time, I think we, like Lisa would well know this, we work together on many of these, have tried to write it into proposals that the process was really one of co-creation with providers, that we really couldn't preempt. And here's some examples of how this might play out, but we wouldn't be able to say. And it was successful in some ways, and other ways, no, depending on, who the donor was. I do think, though, that for me, one helpful thing that has happened, and this new work that I'm just starting with this Healthy Brains Global Initiative work, which is a complete different than international development, but also working with service providers, it comes back to data. And we're building in these kind of performance reviews and really looking at the data around what performance looks like. Because I think that gives an opportunity. It's still concrete, right? A performance review where you take data and you kind of look at it and say, well, what's going on here? Where are we not achieving our goals and why? That feels like a concrete activity to a donor. And it can be really helpful to trigger a conversation around, well, why, as opposed to sort of, starting at the beginning. So maybe that's an option. I think it also, this new kind of world of different funders and different donors and sort of a different playing field, there might be more opportunity for better dialogue with donors. It's not as much, a $50 million project comes out and there's clearly an expectation of what you're going to do with it. And there's also lots and lots of research already, right? And so you can sort of, even if it's not the actual provider who's actually going to be working with you, there's also a lot we know from having done a lot of this work in the past. And so even trying to build that pathway as part of the response to a donor to say, okay, well, this isn't exactly the same situation, but based on this experience in South Sudan, this is what we did and what was necessary, or what they did or what was necessary. And this is kind of where we'll use this as a best practice and adapt, with our own situation, because there is a lot that has been done in the last few years.
Yes, and we've just been lucky enough to hear a lot of it. So it is 11. We thank you all so much for joining, sticking with us, and a huge thanks to the excellent speakers and commenters. So we look forward to next time. We'll send out the slides and recordings. Thank you so much.